This conference will now be recorded.
So we'll start the lecture. So today topic I'll be taking up another two surgeries. One is CaldWell LUC operation and the other one is antral washout. Now before going to CaldWell LUC operation, just a little bit about the maxillary sinus anatomy. Uh, this maxillary sinus is also known as uh, antrum of high mode. So you can see this is a sagittal section and this is the maxillary sinus, and you can see the relation to the orbit. This is the medial wall of orbit. So maxillary sinus forms the floor of the orbit. Okay, so the upper border or the upper wall of the maxillary sinus forms the floor of the orbit, and this is a three-sided pyramidal structure, and the apex of this is directed towards the zygoma. So towards the zygoma, and in adult, its capacity is approximately 15 mm. So another interesting thing, these all you have, I think you have been told. I'm just revising a little bit to refresh your memory. Here you can see the opening. So this is known as the natural ostium, through which the whatever secretions are there in the maxillary sinus, they drain. Now you see how high up the ostium is, almost near the roof. So then what happens? Naturally, one question will arise: how the secretions over here will go up there? So it is all due to the coordinated ciliary activity. So the ciliary beat towards the natural ostium. So thereby what happens? They keep the ostium free from any secretions, and then and through the ostium the maxillary sinus is ventilated. So in a normal condition, you find air inside the paranasal sinuses. Now this is the coronal cut. You can see this is the superior wall which forms the floor of the orbit, and this is the lateral wall which is related to the cheek, and this is the medial wall which is related to the lateral wall of the nose, and this is the floor. So here and here you have the canine fossa, the canine teeth impression. So this is how at the base is this one. The apex I told you is towards the zygoma, and the base is formed by the medial wall of the maxillary sinus. Okay. So here you can see the posterior wall. So behind the posterior wall, you have a potential space that is called the pterygopalatine fossa. So the pterygopalatine fossa medially is formed by the spinopalatine foramen. Through the spinopalatine foramen, you enter into the pterygopalatine fossa, and then through the pterygomaxillary fissure, you go into the infratemporal fossa. So this is how the continuity is there from the nose to the pterygopalatine fossa and the infratemporal fossa. So if you can recall your juvenile nasopharyngeal angiofibroma, so which arise from the spinopalatine foramen and then spreads laterally to involve the pterygopalatine fossa, and then goes on to involve the infratemporal fossa. So here the floor you can see is related to the alveolar arch of the maxilla. So this is how what happens sometimes, particularly the third molar root goes right very deep into the wall of the maxillary sinus, and sometimes in some instances the bone is dehiscent and is just covered by a mucosal lining. So the any problem with the tooth can directly lead to maxillary sinusitis. So odontogenic etiology for maxillary sinusitis is also very common. So the base or medial wall corresponds to lateral wall of nasal cavity. We've already discussed in relation to middle and inferior turbinates. The ostium of maxillary sinus opens in medial wall and opens into the middle meatus between the uncinate process and the bulla equimodalis. So apex is directed towards zygomatic process, and the three walls of the pyramid are the anterolateral wall covered by periosteum and soft tissue and skin of the cheek. So that is why in case of maxillary sinusitis or any pathology like malignancy or fungal sinusitis, you get swelling of the cheek because when the anterolateral wall is involved. And particularly in case of malignancy, sometimes the this anterolateral wall is breached and the tumor comes right and lies in the subcutaneous tissue, and in some extreme cases can also involve the skin of the cheek. It is relatively thinner in the canine fossa and is present lateral to the canine eminence. So you can see the canine fossa over here. So this is, you can see the canine fossa is marked out for you, and this is the infraorbital foramen. The canine fossa boundaries, you can see superiorly you have infraorbital foramen, inferiorly you have the alveolar arch of the or you can have the medially you have the pyriform aperture, and inferiorly you have is the canine tooth eminence here, and laterally you have is the maxillary, you have the maxilla. Okay, so these are the four boundaries of the canine fossa, and this is the site used for approaching the maxillary sinus in CaldWell LUC operation. So why canine fossa? Because this is thin over here, and then so that with little effort you can drill out, or you can even gouge out this area and enter into the maxillary sinus. This wall has an opening called the infraorbital foramen, which is about 1 centimeter below the infraorbital margin. This is the infraorbital margin, 1 centimeter below that. Okay. So here you can see this is the maxilla bone, and this is the zygomatic bone. You can see, and this is the mandible over here. Okay. The infraorbital nerve and vessel emerge through this foramen. So this is how one of the complications of CaldWell LUC operation is infraorbital injury to infraorbital neurovascular bundle. So because of its close proximity to the infraorbital foramen, sometimes you may injure it. How, I will tell you later. So here you can see this is the different nerves. This is the V2 means the maxillary division of trigeminal. So the maxillary division of trigeminal, from there arises the posterior superior alveolar nerve, and then the infraorbital nerve comes like this, and then through the infraorbital foramen it comes. This is coming through the inferior orbital fissure. Okay, so and then it comes along the floor of the orbit, and then comes out through the inferior, through the infraorbital foramen. So then you have the middle superior alveolar nerve and the anterior superior alveolar nerve. So these are all arising from the maxillary division of the trigeminal. So the superior wall or roof of the antrum is formed by the orbital plate, and this is covered by the orbital periosteum. Okay, and at its midpoint, in its inferior aspect is a groove through which the infraorbital nerve and vessel pass before emerging out of the infraorbital foramen. So here this is the groove which houses the infraorbital nerve, and this is the infraorbital foramen. Okay. Now this is again you can see the different muscular attachment to the maxilla bone, and you can see the articulation with the zygoma over here, and this is the ascending process of the maxilla, or you can say the frontal process of the maxilla, and this is the medial sorry. So this forms the part of the piriform apparatus, the medial margin. Okay, and this is the alveolar process where you have incisor, canine, premolars, and molars. Okay, and then this is the orbital surface of the maxilla, and this is the infraorbital groove. Okay, and this is the infratemporal fossa, which is related to the infratemporal space. Okay, and here it this the orbital surface here gets attached to the ethmoid bone, and here to the palatine bone. So, and different muscles of facial expression are also shown here. The posterior wall is formed by a thin plate of bone and is related to the pterygopalatine fossa. So this consists of the third part of internal maxillary artery, median nerve, and the spinopalatine ganglia. So three things are there. And posteromedially, the bone is attached to the pterygoid plate with a dehiscence called the spinopalatine foramen. So the lateral posterior attachment is, if I can show you somewhere here, you can see this is the pterygoid plates. These are the lateral pterygoid plates. Then you have another one is the medial pterygoid plates. So these gets attached to the maxillary sinus, but still you can see there is an opening here that is called as the spinopalatine foramen. This opens into the lateral wall of nose just behind the posterior end of middle terpene and transmit the spinopalatine vessels and nerves. So spinopalatine, you know, they are the terminal branches of the internal maxillary artery. So the internal maxillary artery again has three parts. So the third part is related to the pterygopalatine fossa. So the significance is particularly in internal maxillary artery ligation or in ligation of spinopalatine artery. You can also in previously they used to do CaldWell. Obviously now everything are being done endoscopically, but still where a lot of but to do endoscopically also you need a lot of training and you should have the proper equipments. So that is how CaldWell LUC operation, which was used previously for ligation of spinopalatine artery when the endoscopes were not in the frame. The floor is formed by the alveolar and palatine process of maxilla. So it lies at or above the floor of the nasal cavity in a child, while it lies at a lower level in an adult. So the floor is quite low down. Here you can see this is the maxillary tuberosity. We are seeing the maxilla from little posterolaterally. So you can see here this is the zygomatic arch, very nice. This styloid process you can see. And this is the pterygoid plate, and you can this is the spinopalatine foramen. So this is the spinopalatine foramen, and here you come is the infratemporal fossa. Infratemporal means just below the temporal bone. So this is the temporal bone here. This whole area is called the infratemporal fossa, so which lies below the temporal bone. And this is the you can see this is the zygomatic This is the zygomatic bone, and this is the frontal bone where zygomatic suture, the zygomatic maxillary suture. So you can get a tripod suture. Here you can also see this is the zygomatic process of the temporal bone. So it fuses with the temporal process of the zygomatic. This is the zygomatic temporal suture. Okay, and this is the maxillary tuberosity over here, and you can see mark infratemporal fossa. So not that high up, somewhere here you will find the because it lies below the temporal bone. Okay. Here you can see the different nerve which innervate the uh, nose and the paranasal sinus. So here you can see the pterygopalatine or spinopalatine ganglia. So this is through the maxillary division of trigeminal. V2 which we are showing now, you had seen that one. So V2, from that the spinopalatine ganglion is derived. Okay, and here you can see this is the posterior superior alveolar nerve, this is the middle, and then here is this is the anterior superior alveolar nerve. So these three nerves arise from the maxillary division of the triangle. Then median nerve you will find here in the medial canal, the median nerve. The median nerve is formed by union of deep petrosal nerve with lesser superficial petrosal nerve. They form the median nerve. Okay, and this is the different, that is the anterior ethmoidal nerve, and then you have the posterior ethmoidal nerve, then you have the nasociliary nerves. Okay, so these are all different nerves which are involved or seen related to the nose and paranasal sinuses. So here you can see this maxillary division continues and forms the infraorbital nerve also. Okay. Now, what is CaldWell LUC? So, defined as a sublabial approach to maxillary sinus through the canine fossa, wherein the maxillary mucosa is radically excised and drainage is established by creating an intranasal antrostomy. So, like you have heard of modified radical or even radical mastectomy. So, this is like radical surgery of the maxillary antrum. So, it is just like a radical mastectomy. So other names are like radical antrostomy, or you can say canine fossa antrostomy, because the approach is through the canine fossa. So indications, very important, will be asked to all of you in either practical or viva voce. Even it's an important theory question. So the most important indication, you see chronic maxillary sinusitis with irreversible mucosal change. This word is very important. Irreversible mucosal change which is refractory to other modalities of treatment. So two things, two important things. One is irreversible and second is refractory. Okay, and then this second indication you can see is a recurrent anteroconal polyp. The word, this give emphasis on this, recurrent. It should be recurrent. It should not be the for the first time. Okay, and if the patient is more than 18 years old, so like your SMR, this surgery also cannot be done below the age of 17 years. So that is very important, because it can cause damage to the roots of permanent dentition when you are giving the sublabial incision. So always uh, make sure the patient is around 18 years of age. Removal of benign tumors or dentigerous cyst or even dental cyst also. As an approach for median, just one. I am in class. I call you. Is it urgent? Okay, okay. Okay, okay. I'm in class. I will come at 10. Okay. Sorry. An approach for video neurectomy, an approach for maxillary artery ligation for intractable epistaxis. So the epistaxis which you cannot manage by routine anterior and posterior nasal pack, you have to go for maxillary artery ligation. And sometimes previously, when they were planning to do a what you say a surgery for juvenile nasopharyngeal angiofibroma, they used to go for this artery ligation. Sometimes they directly also ligate the external carotid artery. Invasive fungal sinusitis of maxillary sinus, hemoantrum, a blowout fracture of the orbit. So the blowout fracture of the orbit will produce a sign that is known as the teardrop sign, like a drop of tear hanging out. The orbital fat will hang into the maxillary sinus. So the blowout fracture occurs mostly over the floor of the orbit, because the floor of the orbit, the wall is thin, and it is also made weak by the groove for the infraorbital nerve. And then even another one or two indications are there, that is foreign body in the maxillary sinus, which you cannot take it out using conventional endoscopic instruments. And transantral ethmoidectomy, previously they used to do transantral ethmoidectomy. So these are the few indications of CaldWell LUC operation. So the CaldWell LUC operation is typically performed under general anesthesia, and although it can be performed under local anesthesia, but patient compliance will be better in general anesthesia. So when the patient is in supine position, local anesthetic is injected into the gingivo-buccal sulcus on the side of operation. So just inject 2% lox in 1 in 2 lakh dilution of adrenaline, and after injecting you just wait for 5 minutes, and then you give a incision is made in the gingiva 1 centimeter from the fixed gingival margin. So why 1 centimeter is taken? Because this 1 centimeter avoids injury to the root of the permanent teeth, because once you injure the root, the teeth will die. Then you have to remove and keep another tooth. And second thing is this 1 centimeter now will help you to suture it after the surgery. So if you give an incision very close to the fixed gingival margin, then we have seen it's very difficult to take the bite. And when you take a bite, the mucosa will be tearing, and then it may cause problem. So this is written over here. Okay, good. So electrocautery can then be used to divide the muscle to approach the periosteum on the anterior face of maxilla. Now, the most important thing over here is the incision starts at the lateral incisor, not central incisor, and goes right up to the second molar. So roughly 5 to 7 centimeter in length. Second lateral incisor to second molar is the incision. Okay. Third molar we don't go. I told you, because the third molar will be very the root will be very much uh, in close association with the maxillary sinus. So you stop near the second molar. Electrocautery can then be used to divide the muscle and to approach the periosteum of the anterior face of the maxilla, which forms the anterior wall of the maxillary sinus. So the incision through the periosteum is made either with electrocautery or with a knife. So once the incision, you have made a bold incision on the periosteum. So a bone deep horizontal incision is made in the gingivobuccal sulcus, well above the roots of teeth between the canine and second molar. So the incision starts from the lateral incisor, but the bone incision you can give between the canine and second. So at this point, you take the Freer's elevator or cotyle elevator and raise the cheek flap in a subperiosteal plane up to the level of infraorbital foramen. So this is the reason why infraorbital nerve injury is frequently seen. So those who are not careful while elevating the flap, they may end up injuring the infraorbital foramen. So once you see the infraorbital foramen or the infraorbital neurovascular bundle, that is the your superior limit of your dissection has come. You have achieved it. Being careful to preserve the infraorbital nerve as it exits the foramen. Here you can see this is a Freer's double end elevator, or you can use this cotyle nasal elevator. Even you can use the Farabuff's periosteal elevator also. And this is a Army Navy retractor, and this is a Fraser suction. These are the equipments which are used. So a Fraser suction is usually used to suck out any blood from the dissection field. Although if the subperiosteal plane is used, the dissection proceeds with minimal bleeding. So I told you, even when you are doing a mastoid, if you give a good infiltration, then you will achieve this. There will be a hydrodissection ready for you, and you will enter the subperiosteal plane without any problem. Army Navy retractors are used by the assistant to retract the cheek and soft tissue to help with visualization. Once the cheek is fully elevated, a 4 mm chisel is used to enter the anterior maxilla in the canine fossa, making certain that the entry point preserves the canine tooth root, which is the longest one. So alternatively, a 3 mm cutting burr can be used to outline the limits of the anterior wall window, and the bone of the anterior wall can be removed in one piece. So like that you can do, or you can cut out the bone like a single piece from the edge. You can, like a window, you can create. And after the surgery gets over, you can put it back also. So, but that requires little expertise. And when you keep it back, no, you have to put screws so that it doesn't move around. So here you can see this is the infraorbital foramen, which you see. This is the Army Navy retractor. You can use two, one over here and one over here. Okay, and then after making the first opening with the help of a gouge mallet, or with the help, then you can use this instrument known as the Kerrison punch or bone punch. So here you just nibble away the bone and make a circular opening. So once this window is opened, a Kerrison ronger is used to remove the remaining anterior wall of the maxilla from the piriform aperture to the lateral maxillary wall, while preserving the infraorbital nerve in the infraorbital foramen and the maxillary tooth roots. The mucosa of the antrum is inspected, and cyst or polyp or benign tumors are removed by elevating the affected mucosa using a suitable elevator. So then after that, you can also if you have an endoscope also, you can use. So the endoscope will also tell you if you insert the endoscope, you can use a 0-degree endoscope. Even you can use an angled endoscope also. This endoscope will tell you where the exact pathology is, so that you can take you can use suitable instruments to remove the pathology. So now, alternatively, a micro debrider can also be used for removal of a polyp or a cyst. Benign tumors are better removed by blunt dissection as adequate tissue is available for histopathological examination. So you just dissect out and then, sorry, you can use a LUC forceps to grasp the elevated mucosa along with the tumor, and you just take it out, pull it out piecemeal. Irreversible disease mucosa of the antrum can be removed completely. So that should be your goal. Otherwise, because if you leave it some mucosa, there is every possibility that this will recur. So here you can see this is a Garrison ronger, and you can see here the bone is caught between the two, and when you press this this segment moves forward and tries to meet this one. So thereby the bone is caught in between, and you just twist it and the bone comes out. Or you can also use a Garrison double action bone nibbling forceps. So you can also use this and just twist it to nibble away the bone. An opening through the anterior maxillary wall 2 to 3 centimeter results from the full removal of bone and direct visualization of the maxillary sinus. Then you do an intranasal antrostomy. This intranasal antrostomy is done in the inferior meatus. Okay. So why you do a intranasal antrostomy? So what happens key, and because this is a radical surgery and you remove the diseased mucosa as well as whatever little bit of normal mucosa is there, that is also removed. So now once imagine without any mucosa how the ciliary activity will occur. So there won't be any ciliary activity, and the opening of natural osteum is way high up. So these patients will have retained secretions in the maxillary sinus. Although secretions will be very few, but still post-operatively bleeding and all those will be there. So they also should be tackled. Okay, and so that is why we make a opening in the inferior meatus. So the opening is made in such a way that it is flush with the floor of the nasal cavity. So it is flush with the floor of the nasal cavity. The lower end of the opening is at the level of the floor of nasal cavity. So you have to make the opening in such a way that the lower end of the opening corresponds to the level of the nasal floor. So inferior metal antrostomy, for that what you do, now you change the position of the patient and give a pack in the nasal cavity, 4% locks with adrenaline, and the inferior turbinate is elevated superiorly using Freer's elevator, and a cottonoid strip soaked on is kept, and to facilitate decongestion of the inferior turbinate. And using a Tilly's antral harpoon, the nasoantral wall is open. Alternatively, you can use Miles nasal antral perforator can be used to perforate the nasoantral wall in the inferior meatus. The opening can be enlarged further by using the reverse cutting edge of the Miles perforator. So to create a large nasoantral window, ostrom backwards cutting forceps or Stamberger's antrum punch forceps also can be used to enlarge the opening. So you have to make it sufficiently large enough, because Post-operatively, it is seen that it shrinks a little bit. So if you are reluctant to make a good opening and have made a small one, then very likely it might close post-operative. So you have to be very, very careful. And this is the Tilly's harpoon. You can see it is spear shaped, and when you puncture through this opening, no, the bone fragments enter are pushed into the maxillary sinus. But when you take this instrument out now, the bone fragment again comes into the nasal cavity, which you can take it out. So these bone fragments are may behave like a foreign body if they are pushed into the maxillary sinus and remain there. It might behave as a foreign body. So that is why the Tilly's harpoon is made in such a way that once you perforate through the bone and you pull it out, all the bone fragments which went in comes out. And this is the ostrum backbiting forceps, which can be used to enlarge the opening of the intranasal antrostomy. So in modern times, CaldWell LUC operation to gain access to the maxillary sinus is still used, but with preservation of as much mucosa as possible. So what they are doing is, if you try to preserve the mucosa, then the epithelialization occurs better and occurs fast. So now the concept is not to remove all the mucosa, but rather try to preserve it, but not at the cost of recurrence. Okay, because this is surgery, patient has come to you because he or she was suffering from recurrence. Now again, by doing CaldWell LUC, if you give recurrence, then it is bad. So closure consists of a single layer of absorbable or 20 acid, running or interrupted. So it depends on what type of closure you want to give. Antibiotic coverage is recommended for 1 week after depending can you please switch off the mic? Whose mic is on? Hello.
4th year అవుతుంది ఇప్పుడు నెక్స్ట్ ఇయర్ వస్తారు నెక్స్ట్ ఇయర్ కూడా రాదు నెక్స్ట్ ఇయర్ వస్తారు రెండున్నరగా మరి నెక్స్ట్ ఇయర్ వస్తారు
Can you hear me?
కూడా సెకండ్ హౌస్ వచ్చేటప్పుడు
Antibiotic coverage is typically recommended for 1 week after the procedure, depending on indication and pathology being treated. So, see, the pathology will dictate what type of antibiotic to use. And usually, you see chronic maxillary sinusitis, the gram-negative organisms dominate. So, your antibiotic which should choose will be such that which has a good gram negative coverage, and if it is secondary to any say Caristor, then you have to include metronidazole because the oral cavity flora contains a lot of anaerobes, so that's why you add metronidazole. So another indication I think which is left out is the Oroantral fistula, which can be repaired by doing a CaldWell LUC operation. Okay. So don't forget Oroantral fistula as one of the indications for CaldWell LUC operation. So ice is recommended for cheek to help decrease the swelling. So that cheek swelling, you have to tell the patient well in advance, saying that there will be some amount of cheek swelling for a day or two. And you can also tell them to bring ice so that immediately after surgery, if they apply ice, no, the swelling is comparatively very less. Sorry, this you can see the opening has been created, and now this is the Freer's elevator. Here we are using the tongue depressor, and this is the Freer's elevator which is being introduced to elevate the mucosa. And then after elevating the mucosa, you can remove the mucosa piecemeal, and then give a thorough wash to the maxillary sinus, and then you can use your angled endoscope or 0-degree endoscope to have a look into the maxillary sinus. Complications. Inferior meatal antrostomy is actually not physiologically optimal for sinus drainage. So Messer-Klinger described the severe physiology of the maxillary sinus, flow of the maxillary sinus, transport mucus to the middle meatus through the natural ostium of the maxillary sinus, through the infundibulum, and then to the hiatus semilunaris. Widening a surgical window inferior to the inferior turbinate ignores this ciliary organization, which preferentially transport mucus to the site of natural ostium. Non-physiologic drainage of this kind fail to resolve mucostasis and thus perpetuate chronic infections. So if the mucosa is left no, then definitely the drainage will be towards always towards the natural ostium. But if you remove the mucosa and totally remove all the mucosa from the maxillary sinus, then this inferior meatal antrostomy works much better. Curettage of the maxillary sinus lining with curettes and other instruments could injure the second division of trigeminal nerve and create a cheek numbness. Superior alveolar nerves, which derive from the maxillary nerve and supply sensation to the teeth, and can also be injured during maxillary sinus curettage. Traction on the intraorbital nerve as it exits the anterior maxillary wall can create anesthesia of the cheek, typically temporary, lasting for days or weeks. Now here you can see how much the I'll show you the diagram. Here you can see, if you are not careful and this retractor, you place it here and then pull it, obviously the maxillary nerve, the infraorbital nerve will be stretched and can lead to either neuropraxic or neurontomesis, whatever injuries. Traditional CaldWell LUC antrostomy poses challenge for satisfactory healing. Removal of mucosa creates large area of exposed bone that require a protracted healing time. So obviously it will take a lot of time. In addition, the regenerated mucosa is not able for increased fibrosis and reduced seromucinous gland. So contracture of the post-CaldWell LUC sinus cavity and obliteration with scar tissue are common. There is also a risk of oroantral fistula. So oroantral fistula is an indication as well as a complication of CaldWell LUC operation. Very important to remember, oroantral fistula is an indication as well as a complication of CaldWell LUC operation. Modern studies on a large scale of CaldWell LUC operations showed a fairly high complication rate, like paresthesia in 9%, oroantral fistula 1%, wound dehiscence 1.5%, and dacryocystitis. dacryocystitis in 2.5%. So these are the complications which you can usually encounter. Along with it, you can also injure the roots of permanent dentition, leading to a dead tooth, and that is also, and sometimes it might bleed also when you do an intranasal antrostomy and remove the bone fragments. No, it bleeds from either the bone or from the mucosa. Role of CaldWell LUC operation in current practice is thus extremely limited. It may have been used in situations where a return to normal ciliary physiology is not expected. Cystic fibrosis, where the chromosome 7 mutation affects the chloride channel of the mucosal lining and cause mucus stasis, chronic mucosal inflammation, and Pseudomonas aeruginosa overgrowth. So it would not be expected for the patient to develop physiologic recovery in this genetic disorder. Primary ciliary dyskinesia is another one known as Carter-Jenner syndrome, where there is genetic ciliary disorder causing generalized permanent mucosal dysfunction. So the word CaldWell LUC approach here is used to mean that the maxillary sinus is surgically assessed through the anterior direct surgical incision in the gingivobuccal sulcus and through the anterior wall of the maxilla. However, curettage of the lining is not done and an inferior meatus nasal antral window is not created. The lesion that may be approached is lateral and inferiorly positioned fungal ball. Foreign bodies related to endodontic tooth or treatment or penetrating tissues. Tumor based on the anterior or anterolateral wall of the maxillary sinus, and the bony tumors such as osteomas that may require extensive drilling. So in this situation, you may rely on a CaldWell LUC operation. Okay. So antral washout is another that is called antral lavage or proof puncture or antral washout. So indication are diagnosis of sinusitis. The returning fluid is collected in a kidney tray, and this returning fluid you can send it for culture, antibiotic sensitivity. You can send it even for for cellular, see what is the cellular pattern, whether you are getting any malignant cell. You can do even a fungal KOH mount or even fungal culture also you can do. A lot of things can be done. Okay. Treatment of acute and subacute maxillary sinusitis and pansinusitis not responding to conservative management. So even though there are like particularly pressure symptoms, so patient is having throbbing pain on the maxillary sinus, and he or she feels as if the sinus is full with something, and that sinus is expanding and the pressure I can feel it. Contraindication under 3 years of age, hypoplastic maxillary sinus with thick wall, acute febrile maxillary. So always try to avoid in case of acute infection. So you give the antibiotic treatment, and after 1 week you assess the patient, and then you can go for antral washout. So in a case of acute febrile maxillary sinus, it is not done to prevent development of osteomyelitis or septicemia. And disruption of orbital floor can occur with injury to the orbital fat, and even you can also get orbital cellulitis also. So if there is disruption, no, if there is a discontinuity or dehiscence, then it is a relative contraindication. You can do it, but you can do it carefully. So if you are not careful, no, then you may puncture through the dehiscence. You may go into the orbit, and then what it will cause? It may lead to orbital cellulitis. So done under local only, no general anesthesia. So 10% cocaine and 1 in 1000 adrenaline placed in cotton plaquettes in the inferior meatus at genu and middle turbinate. So inferior meatus visualized with you make the patient. Usually what we used learn is you can do it in sitting posture, which is the best, or even you can do in supine posture also. But sitting posture, uh, you make the patient comfortably sit in front of you, and then after removal of pack, you have to take the Tilly's antral and just pictures. Sorry. This is the Tilly's. You can see Lichwich trocar, and this is the cannula. Okay, and then what you do is you take the tudicum nasal speculum, open the nose, nostril, in fact, and then you insert this cannula into this, so that only a small bit of this much piece of pointed trocar is visible. So, and then where you have to insert is 1.5 centimeter posterior to the anterior end of inferior turbinate, and then there you have to puncture, and then with screwing movements you have to drill like with your hand, and then the always it is directed towards the lateral canthus of the eye. So the direction of the uh, which trocar and cannula will be towards the lateral canthus of the eye. So once the trocar and cannula is in the maxillary sinus, which you can appreciate by sudden giveaway sensation, then gently you hold the cannula and remove the trocar. So now the trocar is out, the cannula remains in the maxillary sinus. And then this is a unique, this is a Higginson syringe, and this has a valve over here, so that prevents the backflow of water. So before puncturing, no, you make sure the volume of this is almost 25 to 30 ml, okay, of this bulb. So what you do is this side you can remove this, and then after removing this black covering, you can directly attach to the trocar here. Sorry, to the cannula here. And then before doing that, no, you make sure you fill the bulb with saline, 30 ml saline, and then you just press the bulb, and then the saline is pushed here and goes here, and then comes here, and then goes into the maxillary sinus. So once the saline goes into the maxillary sinus, what happens? The whatever mucosal plug is there, which is obstructing the maxillary ostium, comes is forced out into the nasal cavity. So here one thing you should keep in mind is whenever you are pressing the bulb now, and for the saline to flush, you ask the patient to hold his or her breath, and then you flush it. So you continue to flush until the returning fluid is completely clear, and then at the end you have to flush around 20 to 30 cc of air, so that whatever a little bit of saline which stays comes out, and then you make sure that now the maxillary sinus is free of any either pus or fluid, anything. All are taken out, and at the end you push in the air. So avoid air introduction, and that is not in the not in the beginning, but towards the end you can push 2-3 puffs of air, so that whatever remaining few ml of fluid will be there, it comes out. Complication, most common complication is not written here. It's a vasovagal attack. A patient may collapse, and then you may have a mild hemorrhage. Pain and swelling of cheek, that is occurs only when you have a false passage. Instead of entering the maxillary sinus, no, your trocar will be in the cheek, in the muscular soft tissue of the cheek. And if you are not aware and you push the saline, immediately the swelling will develop, and it is very painful also. Perforation of the orbital floor or posterolateral wall also can occur. This is the position. See, patient is nicely seated, and we are doing the antral puncture. You can see while introducing the what you say, the trocar, you hold it like a pen, and then you change the grip to a much stronger grip, and then a rotatory movement in the direction of lateral canthus. Okay. So any questions you want to ask? Any doubt, please ask. Anyone having doubt? Student? Anyone having doubt? At least respond. Okay. So we'll meet in the next class.